Good morning, everyone. My name is Gaurav Talwar. I'm a second-year general surgery resident from McMaster University and feel very fortunate to present this project on the use of the Modified Frailty Index to predict post-operative outcomes in patients undergoing surgery for ASBO. Green forward. Perfect. I have no disclosures for this presentation. So approximately 10% of patients who come to the emergency general surgery wards tend to have an adhesive small bowel obstruction. In general, patients who otherwise have no indication for an emergency surgery can trial a day of non-operative management for 3 to 5 days. 75% of these patients succeed, and the remaining 25% end up going to the operating room and tend to have actually reduced recurrences thereafter. As we'll figure out later on in another presentation, I believe, there are some investigations in terms of predicting who will require surgery in the first place. However, there's very limited data in predicting how patients will actually do once they undergo their surgery itself, especially when they're really old. The limited literature thus far includes a study that was done in 2006 that developed an 8-parameter model, but it included things like wound classification, so you can't really predict that prior to the operating room. Asuzu et al. In 2018 created a 3-parameter model that looks really nice, but unfortunately just included open cases, so it doesn't really generalize to the world of MIS. And the NSCOPE ACS calculator that I commonly use in my own practice has been shown to over and underestimate specific complications when it comes to specific procedures outside of the NCQIP database itself. So there's a void in literature. That's where the Modified Frailty Index comes in. It essentially consists of 11 parameters that you can gather on a basic history in the preoperative consultation. You add up all the variables that the patient has, and if you have 3 or more, you're considered frail. If you have less than 3, you're considered robust. And we try to see whether or not stratifying patients by that can help predict the outcomes that they'll have after the surgery itself. To do this, we performed a multi-center retrospective chart review of all the cases in our institutions at St. Joseph's Hospital and the Hamilton Health Sciences for adult patients undergoing this surgery, but specifically looked at people outside of who had the OR more than 24 hours after the presentation to avoid the confounding that deranged physiology presents when you're just coming in for a P1 operation. A lot of data was collected. It was quite granular, but essentially the primary outcomes were 30-day complications and mortality, and the secondary outcomes were length of stay, ICU length of stay, discharge destination, reoperation, and readmission. Standard statistical analysis was performed thereafter. So after reviewing 704 charts, we were able to include 133 patients. In general, when we just stratify by MFI, not surprisingly, patients with a higher MFI on the right side were older and more comorbid, more often had cirrhosis, on anticoagulation, and it made sense that they had a higher ASA class and Charlson comorbidity index. However, preoperative characteristics were quite similar, including the time to go into the operating room, and less than 5 days is considered to be a better prognostic marker, so they're similar per se. And operative characteristics were similar as well, with a good balance of laparoscopic cases at least attempted in about 50% of cases, and a good array of surgeries itself from simple adhesiolysis to requiring small bowel resections. In terms of results, again, just stratifying by MFI, higher MFI patients tend to have worse 30-day minor and major complications, as well as mortality, although it didn't reach statistical significance. Had an increased chance of needing the ICU post-operatively, and also were 4 times less likely to go back home. That is, they were more dependent thereafter than they were beforehand. As you increase the MFI along the x-axis, you also notice that the complications worsen, and that brown line coming down is just that there's a decreased chance of them going back home. On multiple regression, however, MFI did not reach the model itself, but dependence, which is one component of the MFI, did, and it was independently associated with worse 30-day overall morbidity, as well as ASA, time from OR, dependence, and age met the criteria for preoperative residence and whether or not they would be able to go back home. So in essence, despite the strong signal that the high MFI showed, it didn't really reach statistical significance in the multiple regression model. And I think that one reason is because it was an underpowered study. Despite including all the charts we possibly could, we typically would require about 360 patients to detect these clinically significant differences, which we were not able to achieve. Also, there's quite a bit of overlap between the ASA class and dependence levels with what the MFI shows. And so sometimes when it comes to statistical analysis, the model may choose one versus the other. Nonetheless, functional dependence did show quite a bit of utility when it comes to making informed decision making. And there were multiple strengths. 34 experienced surgeons were involved in these operations. There's a good balance of laparoscopic and open cases, and there's a focus on ASBO. Limitations, however, include as inadequately powered, it is a retrospective study, and there's residual confounding. And to address some of these concerns, we're currently using the NIS database to answer this exact same question and see if we can get a powered study as well as be able to do subgroup analyses. In conclusion, the MFI, and particularly functional dependence, may be an important factor to consider in your preoperative discussion with families, but further appropriately adequate powered studies are required nonetheless. Thank you for your time, and I welcome any questions.